Okay, sir. Dr. Jan, thank you so much for the introduction. And at the outset, I would like to thank the organizers, Dr. Raman Sardana, as well as all the chairpersons who are there on the dais for this Hospital Infection Society. And today, the topic which has been given to me is monkeypox vaccines. After having two very good speakers, Dr. Meher Rizvi and Dr. Priya Abraham, now I would like to speak on monkeypox vaccines. So can you just check something is coming on the screen? Yeah, now this is better. So now at the outset, I will start with the smallpox vaccination. It is known to be 85% effective in preventing the monkeypox. Now for some 40 years or more, all the countries, they have stopped the smallpox vaccination. So now we have the unvaccinated population, and that makes it susceptible to say maybe the monkeypox also. So few of the countries in the world nowadays they are doing some kind of scientific studies to assess the feasibility and the appropriateness of the vaccination for the prevention and control of monkeypox. Now, way back, we had these smallpox vaccines. These were of three types. The first generation vaccines, which were initially used in the eradication phase of the smallpox. The second generation smallpox vaccine, which is say ACAM 2000, which I'm going to talk about. These are more of purified forms of vaccine, and they are improvised form of the first generation vaccine, which was Dryvax. And now, as on today, we have another third generation group of smallpox vaccine. And the difference between the second and the third generation vaccine is these first and second generation vaccines, they are live. These third generation vaccines, these are more attenuated vaccine strains, and they are comparatively safer as compared to the other or the previous vaccines. So we move to the next one. Can you just check why this is not moving, or shall I use this one? Yeah. So monkeypox cases, they are often treated with all the countermeasures which are closely related with the smallpox virus. So as on today, in the world, we have two licensed vaccines for the smallpox. They are called MVABN, that is Modified Vaccinia Ankara vaccine, which was prepared or manufactured by Bavarian Nordic, and it is licensed in the USA as Genios, and Imvamune in Europe, and Imvanex in Canada, and the second generation vaccine ACAM 2000, which is again licensed in USA. The third vaccine, which may come up, but the present or the current status is it is only for the emergency use authorization. The name of this vaccine is Aventis Pasteur Smallpox Vaccine, and there are few other candidate vaccines for the smallpox which are also there in pipeline. Next, please. So we come to the detailing of this ACAM 2000 vaccine. This is a replication competent live vaccinia virus vaccine. It's a single dose vaccine, and you have to give this vaccine by a multiple puncture technique percutaneously in the deltoid, and you have to puncture the skin at least say 15 times. Maybe even a drop of blood comes, that's all right. We need not wipe off with alcohol. And that's the technique to give this second generation ACAM vaccine. Little cumbersome to give the vaccine. So just last year only, there has been one US CDC Advisory Committee on Immunization Practices in 2021. So nowadays, they are more of recommending on the Genios vaccine as compared to the ACAM vaccine. We will see the route of administration, how it is different. So next slide, please. So next, please. Yeah. So we move to the next one. Yeah. So we can see here now this ACAM 2000 was inoculated. So practically in all the four pictures, you will see that there are the lesions are around say 1 centimeter. On the day 4, we will see a vesicle. On the day 7, is going to be a pustular lesion with a basal erythema and little induration, and subsequently it will crust, and finally it will scar by day 21. Next, please. So now we see here, these are the two pictures which are showing a very detailed picture. This goes like, this is called as a major or a take reaction for the smallpox vaccine. So once we see something like this is what it means, that the vaccine has been taken up by the individual and the immune response is likely going to be very good. So this is what we call as a major or take reaction after a smallpox vaccine ACM 2000. Next, please. Now, once we give this ACM 2000, we have to take care of the vaccine site also. That means you have to cover the vaccine site loosely, because the vaccine which you have given is, say, live. So it has to be covered with a loose covering or a piece of a gauge as shown in the picture. And since the virus is live, you are not supposed to touch the vaccine site and touch the other side, because you may land up auto-inoculating yourself and even people, those who are around you, and if they are having some diseases. Next, please. Now, what are the expected reactions? These second generation vaccines, they have some expected reactions at the injection site, which are erythema, pruritus, pain, swelling, and several constitutional symptoms, say fatigue, headache, muscle aches, chill, nausea, fever, malaise. So practically say around 1/3 of the people, once they receive the vaccine, for a day, they would like to stay in their house. Next, please. Now, what are the contraindications for the ACAM 2000? Contraindications are many. If you see, this slide talks about contraindications being, say, if you are having a atopic dermatitis, it is contraindicated. Of course, yes, if you have allergy, it is going to be contraindicated. If you have some exfoliative or bad skin conditions, this ACAM 2000 is contraindicated. If you are immunosuppressed, again, contraindicated in pregnancy and age less than 1 year, and even in breastfeeding, it is contraindicated. But if you see on the extreme right, there is a column talking about the household contacts. If you see, if your household contact has got some kind of a skin condition or atopic dermatitis or pregnancy, or even a child who's less than 1 year, still the ACAM 2000 is contraindicated. So this is a very, very important point, and that with all those kind of situations existing with this vaccine, there was a need to develop the third generation of vaccines for the smallpox or monkeypox. Next, please. Now, this slide talks about if supposedly we have the healthcare workers or the occupational exposure is happening in the laboratory personnel, and that exposure is happening repeatedly, particularly from the point of view of, say, Dr. Priya's lab, NIV Pune, or maybe any other lab who deals with it. So if you are dealing with the replication competent vaccinia viruses, they're not too dangerous. So you may require a revaccination after 10 years. And if you are supposedly dealing with more of the virulent orthopox viruses in your lab, say the variola or monkeypox, then the next vaccination or the booster dose is required after 3 years. But if you see, a recent guideline says the new vaccine, which is third generation, it requires booster dose after 2 years. So this ACAM gives a little better protection for 3 years as compared to the newer one, Jynneos vaccine. Next, please. Now we come to this new vaccine, which is primarily called as MVA-BN. This MVA-BN means Modified Vaccinia Ankara Vaccine, and it is manufactured by Bavarian Nordic. This is a vaccine manufacturing company which is located in Copenhagen, Denmark, and this manufactured this vaccine way back in 2013 when it was licensed by the European Medicines Agency for the prevention of smallpox only. But in the last 10 years or so, the vaccine has been used off-label for, say, some monkey cases previously in the UK and in the European Union. So finally, in very recently, just 3 years back in September 2019, US FDA has got the approval of MVABN with the trade name of Genios for the prevention of monkeypox as well as a smallpox. So if I were to say, do we have any licensed vaccine for the monkeypox in the world? Then it has to be, say, Genios. And how about the Europe? Europe, we have got a vaccine which is, say, licensed only for a smallpox. So how did that happen? It is just that the manufacturer remains the same. Whether the manufacturer from, say, Denmark supplies the vaccine to Europe or Canada or, say, USA. So it is the manufacturer who applied for the vaccine only for a smallpox. Therefore, they got the smallpox licensing in, say, Europe. And in the US, they applied for the licensing for both of them, smallpox as well as monkeypox. So they got the license for both of them for USA. But in the backdrop, the vaccine is the same and the manufacturer is the same. Next, please. So MVABN, this is an attenuated live virus vaccine, which is replication deficient. So this point is very, very important. And the vaccine, as on today, it is recommended only for adults more than 18 years of age who are at a higher risk for maybe smallpox or monkeypox. And this comes in a single dose vial of 0.5 ml. And it has got a certain composition of chromitol, sodium chloride, WFI, gentamicin, and benzonase. Next, please. So this Gynos vaccine, this is basically a suspension which comes in a single dose of 0.5 ml, and it has to be injected subcutaneously in the deltoid, preferably in the upper arm. Now, the difference with the ACAM is, ACAM we were administering as a single dose. Now, this Gynos we have to administer as 2 doses, which are going to be at least 4 weeks apart. So this is a very, very important vaccine. The second generation ACAM 2000 is a single dose vaccine. Gynos, which is, say, 4 weeks apart, 2 doses for this third generation vaccine. Now, this vaccine has to be thawed. It has to be brought to the room temperature before you give it. You can hold it up at 2 to 8 degrees Celsius for maximum 12 hours. And as it is in the right form to give, this looks like a milky light yellow or to pale white in color as a suspension. Next, please. Now, what are the side effects of MVABN? The side effects which are very common means which affect more than 1 in 10 people. These are headache, muscle ache, feeling sick, tiredness, pain, redness, very usual side effects, nothing much to bother about. And the common ones are, which are, say, 1 in 10 people they get it, which is going to be the fever, chills, joint pain, loss of appetite, and so on. And there are some uncommon ones also, which affect, say, 1 in 100 people, which may be some kind of a throat irritation, respiratory infection, swollen lymph nodes, and so on. Next, please. Now we talk about the MVABN efficacy. So this point is very, very important. How good is this vaccine which has been newly developed, say, for the smallpox or monkeypox? Naturally, it was compared with the previously established vaccine called ACAM 2000, and it was found, say, in a non-inferiority trial to be not at all inferior to ACAM 2000. Basically, they did a study in which they gave the 2 doses of the MVA to a person, followed by ACAM 2000, and in one group, that was called the MVA group. And in the other group, they only gave, say, a single dose of the ACAM 2000 as a standard dose. And they compared the 440 participants, and the results were just the same. So the non-inferiority trial was proved. And this phase 3 trial has been published in 2019 in New England Journal of Medicine. And if we compare what kind of, the neutralization titers were achieved by both of these vaccines, the ACAM versus MVA or MVA versus ACAM. So the answer is after 2 weeks, the titers which were obtained by both the vaccines, they were more or less the same, and the seroconversion was also more or less the same, 90 to 91%. Next, please. Now we move to the next one. How about supposedly the immune response has happened? So how long these antibodies they are going to persist? And will they require any booster? That's a very important question. So those studies, they were done, and after that it was realized after 2 years of giving the MVA-BN, the neutralization antibody titer was only 1.3, and the seropositivity amongst the individual was only 5%. So that means if we are giving MVA-BN, the immune response is going to last for roughly 2 years, and we will require a booster dose, say at the end of 2 years, which is different from the ACAM 2000, where we require the boosting after 3 years. Next, please. Now, for the use in children. Now, as I said, MVA-BN, it's a new vaccine, but by far it is not licensed in children, right? So this is a very important point. But it is licensed only for more than 18 years of age. So what do we do now? Can we give the answer is going to be for the pediatricians, say if supposedly the children, they have the monkeypox, can we give this vaccine? The answer is, since the vaccine uses, say, the vaccinia virus, which is attenuated, in the similar trials which happened for tuberculosis and the malaria, where the vaccinia virus was used, so since we didn't have much of the side effects and the safety profile was all right, so we expect that it is going to be comparable. So this gives us some reassurance that in the times of the come, maybe this vaccine is going to work in the children, and approved it for the children also. Next, please. Next question is again for the pregnancy and the breastfeeding. Supposedly somebody is pregnant and is exposed to the monkeypox or develops monkeypox, what happens then? Will this vaccine be useful? Or if somebody is breastfeeding, what we should do? Should we give or should we not give? So as of today, the answer is, in both the situations, the vaccine is not contraindicated. The reason being the safety profile is just the same in both the situations. But it is always better that at the end of the day, the risk-benefit ratio should be assessed before you vaccinate. Next, please. Then in those people who have the underlying conditions, say the immunosuppression, how do we deal with them? Now, if you remember the ACAM 2000, which I said, it is completely contraindicated in the atopic dermatitis as well as the exfoliated drug conditions. But here, this vaccine, Genios, we can give in the atopic dermatitis, but the chance of having a reaction is much higher as compared to, say, the other one. But still you can give. I'm not saying the reactions, they may not happen, but the chance of reaction is there, right? But it can be given. It is not contraindicated. So that certainly stands as an advantage over and above the ACM 2000, where you just can't give. And then even for the, say, immunosuppressed people, those who have the HIV, even the CD4 count less than 50, and those who are on immunosuppression, even for those people, this vaccine can be given, because here the virus which we are using, it is attenuated virus as compared to the ACAM where it is live. Next, please. Now, in the pre-exposure prophylaxis, how do we use this MVA-BN for the pre-exposure? Now, this complete vaccination course needs to be given for 2 doses. They should be at least 28 days apart in an immunocompetent person. And for those individuals who have already received a single dose of the smallpox vaccine, say ACAM 2000, you may give another dose of the MVA-BN. It can be given. So what I'm trying to say by saying this is, supposedly some previously a laboratory worker or a healthcare professional who received a single dose of, say, ACAM 2000, and now some few years they have passed, and again, the risk is involved. So can we give this 3rd generation vaccine, which has got less of side effects? The answer is yes, we can, because the boosting is going to happen. Next, please. Now we talk about the post-exposure vaccination. This is very, very important, because this is the strategy which most of the public the health authorities, they would like to experiment or use as a tool to contain the outbreak, which is post-exposure vaccination. Now, one has to understand here is the vaccination should be administered as soon as possible, ideally within 4 days of the exposure, right? Now, if it is given within 4 days of the exposure, it can actually prevent the disease or attenuate the disease. But if you give after 4 days or the 4 to 14 days, if you give the vaccine, then it will not prevent, but it can theoretically attenuate the disease. This is what needs to be understood. And what else? For those individuals who have received a single dose of MVA-BN previously and now they get exposed, so for them, they must complete their course of MVA-BN as a second dose for the complete protection. Next, please. Now, supposedly we don't have a vaccine, or supposedly we get a vaccine. Now, how we prioritize the vaccine, whom to give, whom not to give? The dictum is very simple. Decide, are we giving pre-exposure or post-exposure? Now, out of that, leave the people for the pre-exposure. Only intend to give for the post-exposure. Now, amongst the post-exposure, still the vaccine is very less. We still need to prioritize. So who should get the vaccine? You should give the people who have a higher level of exposure. Those who are actually being exposed, they receive the vaccine as compared to the people who have got a lesser risk of this, getting the disease. Now, third is amongst the contact. This third point is also very important because somebody has got a monkeypox and now there are contacts. Now, amongst those contacts, they will also ask for the vaccine. So how do we handle them? Now, those people who are a definite contact and they are exposed, say, within less than 4 days, to them, vaccine is going to be far more effective as compared to those who have crossed the 4 days after the exposure. Next, please. Now, just one slide to mention the vaccinia immunoglobulin. This is going to be taken up detail, I'm sure, in the treatment, but just 1 or 2 lines are important. Therefore, I made this a slide. Vaccinia immunoglobulin is licensed in the FDA just for, say, in the ACAM 2000, we have lots of reactions. So sometimes we have eczema vaccinatum, progressive vaccinia, severe cases of generalized vaccinia. So you have given a vaccine and the immune response is so high that it is kind of dangerous for the person. It needs to be treated. So in that situation, the vaccinia immunoglobulin has been licensed by the FDA. Now, the other point which I want to just say is the CDC is still working on developing the 4 new monoclonal antibodies for the vaccinia, which are not there in the market as of now. This will take more of research to develop and purify and market them. And one more point, I feel should everybody or the clinical side should keep in mind is defer the vaccination with the live vaccine until approximate 3 weeks, 3 months after the administration of the vaccinia immunoglobulin, because vaccinia immunoglobulin is going to interfere with the live virus vaccines, say mumps, measles, rubella. These are the vaccines, or maybe say chickenpox. So if they should be, say, at least 3 months apart. Next, please. Now this slide, in fact, I took from Dr. Sewell's, and this slide is primarily coming from CDC Atlanta. Now this compares more or less about both the vaccines, which are, say, ACAM 2000 and Jynneos. Now, if we just see the summary of the 2 vaccines, the vaccine virus in ACAM 2000 is replication competent. In Jynneos, it is replication deficient. And if we see the ACAM 2000, there's a major reaction, which is called a take. There is nothing of that sort, though no major reaction in Jynneos. And inadvertent inoculation and auto-inoculation, people, they are at risk in ACAM 2000, and in case of Jynneos, there is no risk. Serious adverse events, the risk exists with ACAM 2000. And in case of Jynneos, there are fewer as compared to ACAM 2000. And then cardiac adverse events, more of with ACAM 2000, say there are 5 people out of 1,000 who get the vaccine, they may have myopericarditis. But How about Genios? Are we trying to say this will not give any cardiac adverse events? It can give, but the point is they are little less as compared to the ACAM, right? This is where we are in terms of cardiac adverse events and then effectiveness of the vaccine. Now, how did we know that the ACAM 2000 second generation vaccine is as effective? We compared it with the first generation vaccine, Dryvax, and the response was very, very good. And this Genios vaccine, the newer one, has been compared with the ACAM 2000 as well as the animal studies, which proves its efficacy as well as effectiveness. And then the administration, as I said, ACAM, little difficult to administer. You've got a bifurcated needle, and it takes a drop of the vaccine, and you have to give at least 15 multiple punctures percutaneously. On that account, Genios really scores over the ACAM because it can be given subcutaneously in 2 visits, and these are 28 days apart. Next, please. Now, if we see some 10 years back, how the world or the international agencies, they were looking at the smallpox issues, their preparedness, and how we can prevent, what we can do. So at that point of time, since there were only 2 vaccine ACAM 10 years back, only 2 vaccine ACAM 2000, and this Genios is coming in 2019. Previously, there was Imvamune and Imvanex. So the recommendations were which of them is better, which of the 2 should be stockpiled, which of them should be targeted for use in an outbreak, and which of them can be used, say, maybe for the general population or maybe the preventive use. There were a lot of questions which were deliberated by the committees in the past. And let us see what their point of view has been. Next, please. So the Global Advisory Committee on the Vaccination in 2016 said, whether it is ACAM, whether it is MVABN, there are new safety concerns. Whatever side effects they have, they have. There is nothing more to add or delete to it, right? So what we should do now, GACVS, which is Global Advisory Committee, recommends that any use of the smallpox vaccine can be guided by the anticipated risk versus benefit presented during the various outbreak or exposure scenario. So this line says very clearly, there cannot be any kind of a blanket strategy which says, give it to the population, give it to the entire group. No, it has to be analyzed in a given outbreak on the basis of the level of the exposure, where to give, where not to give. And if supposedly the benefit is higher than the risk, only then it is recommended. Next, please. Now, the last slide to me is the smallpox vaccine emergency stockpiles in the world, where they are. WHO headquarters has a physical stockpile in Switzerland of 2.4 million doses, which can be reconstituted and delivered by bifurcated needles. So that means this is ACAM 2000. And there are certain doses of the smallpox vaccine which are held by the donor countries. There are some 31 million doses. This is as per the WHO fact sheet, which are France, Germany, Japan, New Zealand, and United States. So we come to the next one. So I think this is the last one. Okay. Thank you, everyone.